Hey, hi, good night, everyone. So tonight we're going to tackle the topic of the basal ganglia, the basic structure of the function of the basal ganglia, and we're going to talk a bit about some movement disorders. It's a bit of a broad topic, but try to incorporate all the relevant aspects of the movement disorders into it as well, right? So first we talk about the basal ganglia, the basic structure. So what is the basal ganglia? Well, it's a group of subcortical nuclei, and it plays a role in the basic control of movement by the regulation of the upper motor neurons. And when we talk about the upper motor neurons, we talk about the motor cortex as well as the supplementary motor cortex. And so it facilitates movement, whereas the other nuclei suppresses it. In terms of the basic functions, it's involved in the planning of movement, the modulation of the cortical bulba, as well as spinal output, and it influences the tone and movement of the skeletal as well as the eye muscles, and cognitive functions in certain types of memory, such as more motor type memory, such as procedural memory, and there's a poorly understood function with respect to emotions. What it is, it's basically a loop through the basal ganglia, right? It links the cerebral cortex with the motor cortex. So in terms of the circuits, it's cerebral cortex to basal ganglia to thalamus back to cerebral cortex, which will then close the circuit. And we'll look at that in a little more detail here. So one point to note is that there are no major sensory inputs to the basal ganglia, and no motor tracts originate in the basal ganglia. So it influences movement by the regulation of the activity of the upper motor neurons. And the key word here is regulation, because regulation is relative, meaning that you could have disinhibition or you could have inhibition. It's all relative in terms of the type of input received by the type of neuron, which we'll see, dependent on the pathway. So in terms of the basic components of the basal ganglia, um, so we're looking at the upper motor neurons, which is the motor cortex. We're looking at the striatum, which consists of the caudate nucleus and the putamen. We're looking at the globus pallidus, which consists of an external part and an internal part. And we're looking at the subthalamic nuclei as well as the substantia nigra. One point to note is that you will see the term the lentiform nucleus, which is a combination of the putamen and the globus pallidus. Striatum or the corpus striatum is a combination of the caudate nucleus and the putamen, just in terms of your terminology. And this basically just breaks down what I just said with respect to what composes each of the different components. So the caudate nucleus, it's a C-shaped mass with a head, a body, and a tail. So it isn't just a one subcortical structure, but it's a three-dimensional structure if you want to think about it. And it's derived from the telencephalon. And the head bulges into the anterior horn of the lateral ventricle and it forms the floor. And it's also continuous with the putamen. The body of the caudate nucleus lies in the central part of the lateral ventricle, and the tail forms the roof of the inferior horn of the lateral ventricle. Of to note as well is that the head is also fused with the lentiform nucleus inferiorly, and it forms a structure called the fundus striati, and the tail lies in close relation with the amygdaloid complex in the medial temporal lobe. The lentiform nucleus, as well as the taken into account the putamen, it's roughly appears triangular in the coronal section, and the apex is pointed medially. It is divided by a white thin line called the external medullary lamina. And one thing to note about the putamen is that it is derived from the telencephalon, and it lies medial to the insula and is bounded laterally by the fibers of the internal capsule and medially by the globus pallidus. So it's sandwiched somewhat between the globus pallidus as well as the insula, as well as the claustrum as well. The globus pallidus, uh, unlike the putamen, is derived from the diencephalon, and it constitutes the inner part or the inner component of the lentiform nucleus. And it's, again, as I stated before, it's divided into an external part and an internal part, and this time it's divided by an internal medullary lamina. So we look at the substantia nigra, and like the globus pallidus, unlike the globus pallidus, it's mesencephalic in origin, meaning that it derives from the midbrain, and it's present between the tegmentum, which is like the mass or the body of the midbrain, and the basis pedunculi. And it consists of two parts, the pars reticulata, which is functionally related to the globus pallidus internus. So it's somewhat anatomically continuous with that. And the neurons, they are predominantly inhibitory in that they are GABAergic. And the pars compacta, which is more clinically relevant to our talk here, in that it appears black on stained sections, as well as in the postmortem states. And the neurons are quite rich in neuromelanin and are primarily dopaminergic. So we'll see more about the substantia nigra when we talk about Parkinsonism and Parkinson's disease and whatnot, as it's more clinically relevant to that. We look at also the subthalamic nucleus, one of the other components of the basal ganglia, and it's derived from the diencephalon, and it lies dorsomedially to the posterior limb of the internal capsule and somewhat dorsally to the substantia nigra, and it acts as more of a relay station in that circuit. So again, looking at the coronal section, right, we see the important parts: the caudate nucleus, the putamen, the globus pallidus, subthalamic nuclei, as well as the substantia nigra. And we see other extra anatomical parts as well, other ancillary parts, I should say, being that of the external capsule. We have the claustrum, the extreme capsule, and over here we have the so it's all bounded. It's all bounded laterally towards the main components of the basal ganglia. Of note is that the main blood supply to the basal ganglia is usually that of the medial and the lateral lenticular striate arteries. So medially, usually derived mainly from the anterior cerebral, lateral derived from the middle cerebral arteries. Other contribution is the anterior choroidal artery as well. Of note is that the main. Okay, so yeah, so in terms of the blood supply, you look at the medial and lateral lenticular striate arteries, each derived respectively from the anterior and middle cerebral arteries, as well as the anterior choroidal artery derived from the internal carotid, near the terminal portion. So of note is that the main types of neurons that project to the striatum, as well as the lentiform nucleus, are the medium spiny neurons, which are usually glutaminergic or excitatory. So this is just a diagram. Now we'll talk about the direct and the indirect pathways. Now anatomically, these are just physiological pathways in order to understand more of the physiology behind the basal ganglia, but they are more used. It's more of a man-made construct in that the direct pathway, there's anatomically there's no difference between the pathways; they're all intermingled. But looking at the direct pathway, right? We call it the direct pathway because it goes straight to the thalamus, and from the thalamus you have the thalamocortical fibers feeding back into the motor cortex. So we start at the motor cortex. You have your excitatory fibers that project to the striatum. When the striatum is now activated, it the red arrows, right? This means that they activate GABAergic or inhibitory fibers now to the globus pallidus. So, and the substantia nigra. Now, this is important because what this means is that it basically deactivates or dampens the activity of these two components. So if you're going to dampen the activity of the substantia nigra, it means that their inhibitory effect is going to be less on the thalamus. What that means is that the thalamus is going to be more stimulated because there's less dampening effect. So if the thalamus is more activated, thereby when it feeds back into the motor cortex, it is going to essentially allow for the activation of the motor cortex. So we say that the direct pathway is involved in the activation, where it promotes movement or promotes the planning of movement, essentially by disinhibiting the thalamus and the substantia nigra as well. We look at the indirect pathway. We call it the indirect pathway because it does not lead straight to the thalamus, but it takes a little detour. So again, we start back here at the motor cortex. It goes to the striatum, but instead of going to the globus pallidus, internus, and the substantia nigra, we make a detour to the globus pallidus externus, and then to the subthalamic nucleus, and then it goes back to these two components here, the GPI and the substantia nigra. So what happens in the indirect pathway? So let's start over again. So you have your motor cortex. It's going to send excitatory or glutaminergic fibers to the striatum. The striatum is going to project your inhibitory fibers to your globus pallidus externus. So it's going to dampen the activity. There's going to be little activity coming from here. Therefore, it's going to therefore that results in more activation of the subthalamic nucleus. If the subthalamic nucleus, if the signal from that is strong, meaning that there are more excitatory fibers deriving from the subthalamic nucleus, that means that it's going to greatly activate the substantia nigra and the globus pallidus internus. So now that this is greatly activated, it's going to send a lot of inhibitory neurons or GABAergic neurons to the thalamus. The end result is that we are now going to dampen the effect on the thalamus. We're going to dampen the activity by supplying it with a lot of inhibitory neurons. Therefore, we dampen the effect on the thalamus. It feeds back into the motor cortex, and it's going to inhibit the motor cortex. So it reduces motor cortical stimulation, thereby decreasing voluntary movement. So direct promotes movement, indirect inhibits movement. And we could see the effect when we talk a little bit more about Parkinsonism and Parkinson's disease with respect to when we remove the substantia nigra, right? So again, the direct pathway is responsible for the stimulation, for the disinhibition of the thalamus, so to stimulate the motor cortex. The indirect pathway is responsible for the inhibition of the thalamus, so it suppresses the motor cortex. And the substantia nigra plays quite a chief role in both of these pathways, along with all the other components. So that's it mainly for the basic structure and the working and physiology of the basal ganglia. And now we're going to go into a bit more on how they relate to your different movement disorders. Now, the movement disorders, it's wide. It's a wide class. So I've tried to just include the relevant things here, right? But it's a huge topic in itself. We're looking at the Parkinson's disease and the Parkinsonism. We're going to define what is Parkinsonism and the Parkinson plus syndromes. We're going to look at tremors, which are neurosurgically relevant, dystonia, chorea, tics, and myoclonus. So Parkinsonism and Parkinson's disease. What are they? When we refer to a patient as being Parkinsonian, it doesn't necessarily mean that they have Parkinson's disease, but they have a constellation of signs and symptoms. So they are akinetic, meaning that it's usually a defining and principal feature of of being Parkinsonian. Bradykinesia, meaning that there's poverty of movement, right? Small amplitudes of movement, or hypokinesia, difficulty initiating movement, rigidity, usually of the cogwheel variety because of a superimposed tremor, right? But this is not always present. And another thing is that there's usually fatiguing and decrementing amplitude of repetitive alternating movements. And this particular feature distinguishes from true akinesia from pyramidal or cerebellar disorders or slowing. One thing to note again is that tremor may not be a major optional feature. It features in about 80% of patients with Parkinsonism, and it's usually a 4 to 6 resting tremor. And they call it a pill rolling tremor because the patient usually looks as though they're rolling a pill between the index and the thumb. And it typically subsides or lessens with movement, only to reappear again after an interval when a new static position is achieved. And they call that a re-emergent tremor. The classic rest tremor, particularly if accompanied by a jaw tremor, is a strong indicator of Parkinson's disease or drug-induced Parkinson's disease. Another cardinal feature of Parkinsonism is that of postural instability. As well as a flexed posture may or may not be evident in the early disease. And postural instability is more of a late feature of Parkinson's disease, as opposed to one particular Parkinsonian plus disease, which we'll talk about. So molecular studies have helped us to basically classify the degenerative Parkinsonisms into two categories based on the presence of inclusion bodies, as well as different proteins that we would see on molecular studies. So they have the alpha-synucleinopathies, which consist of Parkinson's disease, Lewy body dementia, multisystem atrophy, and you have your tauopathies, which usually consist of progressive nuclear palsy and corticobasal degeneration. Parkinson's disease is a very important clinical pathologic entity, and in which you have a patient that is responsive to levodopa without atypical features. And you have the specific areas of loss, of neuronal loss that we see is in the substantia nigra, as said before, which contains a lot of dopaminergic neurons, as well as the locus ceruleus, containing your noradrenergic neurons. If the pathology is usually much more widespread and it involves the serotonergic rapid nucleus, as well as the mesolimbic pathways and the tuberoinfundibular pathways, as well as the nucleus basalis of Maynard, right? As well as the hypothalamus, olfactory tract, and sympathetic ganglia. So Parkinson's disease, it not only involves the degeneration of your substantia nigra, it could involve all the degeneration of those pathways as well. So an example is that some of these patients, a non-motor sign is anosmia or hyposmia, meaning that they can't smell as well because of the degeneration of the olfactory tract. Right? So the overall onset is usually about 60 years, and only about less than 5 cases start before 40 years. So a point to note is that there's a lot of clinical heterogeneity in the Parkinson's disease, and there's a lot of mutations that they identified within the last decade. So Parkinson's disease, it was once thought to be as a static disease, meaning that it's just Parkinson's disease, but we now know that it's actually a spectrum, and there's the Parkin1, Parkin DJ1, Pink1, etc. Type of genes that are involved in this, and patients with alpha-synuclein mutations or triplications, they usually present younger and have a higher incidence of dementia, and usually the survival rate is lower. So one of the important tools that they created in order to aid us in the diagnosis of Parkinson's disease was the UK Brain Bank diagnostic criteria for Parkinson's disease. And it's quite extensive, but it basically breaks it into three steps. And you have your core features in step one: bradykinesia, muscular rigidity, arresting tremor, and postural instability. You have your disorders that would exclude or make it less likely in step two. And you have, in step three, you have supportive criteria, which may or may not be essential for the diagnosis, but helps to strengthen your diagnosis. And in terms of your differentials, right, the list is massive, right? And this was taken from the Queen Square Neurology textbook in order to show that it's usually there's a lot of differentials varying from the Parkinsonian plus syndromes to other various genetic type diseases. So one of the things is that we need to know about is that the different features of Parkinson's disease. So we're looking at the premotor features. These usually only come about when you have about 60 to 80% of the degeneration of the nigrostriatal fibers. When that reserve is lost, then we have the appearance of the symptoms. And PET scans have been used to estimate the duration of the premotor phase between 3 to 6 years. So in the early stages, Lewy bodies are restricted to the medulla as well as the pons and the anterior olfactory structures. But in the later stages, you have the nigrostriatal tract involved. You have a lot of different symptoms ranging from constipation, autonomic instability, and very importantly, REM sleep behavior could precede the onset of Parkinsonism by years. And in REM sleep disorder, there's usually a loss of muscle atonia that accompanies dreaming, somewhat of a protective mechanism so the individuals don't act out their dreams in REM sleep. So we see that in early Parkinsonism, this is lost. And one common complaint is that the spouse or the significant other of the patient will complain of being hit during sleep because of REM sleep disorders. So you have your premotor symptoms and you have your typical motor features. And most patients at the time when they present usually have these well-known motor features. It's classic. Parkinson's disease is classically a very asymmetric disease as opposed to a symmetrical disease, remaining so mostly throughout its course. And it commonly starts in the arm with impaired dexterity of tasks and with a tremor at rest. And there's a tendency to drag one leg or to shuffle or what we call pestinate. And the relatives could also notice a change in facial expression or impaired arm swing. And direct question could reveal a change in the voice in terms of the volume, as well as the fluctuations, as well as intonation. Examination will often reveal akinesia, usually with rigidity and a tremor. And one of often the earliest tremor to be observed may be an adduction tremor of the fingers. Sometimes the only time a resting tremor is observed is on walking with reduced arm swing, flex posture, and gait abnormality. Sometimes that's the most prominent feature when we're looking at the gait. Now, in terms of, there's a lot of different atypical features here, but these are just some of the noteworthy ones, is that in some Parkinsonian disorders, right, there could be a limitation of convergence or gaze with normal saccadic velocity. Sometimes you could have what we call the striatal toe, meaning an upgoing toe that could mimic a Babinski response. And it could possibly make you think, okay, is this a space occupying lesion, or is this some other higher cerebral disorder happening here? We also have dystonic claudication in younger patients and prolonged walking, meaning that on prolonged walking, the muscles will now begin to contract uncontrollably, and it usually could be mistaken for vascular claudication, as well as early postural instability in some cases. So this is just an example of what I was talking about with respect to the striatal toe. It could be mistaken for an upgoing plantar response. In terms of your non-motor features, they are many and varied, such as sialorrhea in later disease, drenching sweats, which is indicative of autonomic instability, urinary urgency and frequency. Depression is quite common in about 40% of patients, as well as a cognitive impairment. It's usually more of a mild dysexecutive type syndrome as opposed to Alzheimer type picture. In terms of our investigations, usually patients less than 40 years should always be screened for Wilson's disease or hepatolenticular degeneration with a serum copper and ceruloplasmin, as well as a slit lamp examination. Usually less than 40 years, we have to think about other causes before we think Parkinson's disease, although not impossible. Routine MRI brain is usually normal in Parkinson's disease and is not particularly warranted. However, there is the dopamine transporter single photon emission computerized CT or the DAT SPECT scan that could be used to confirm a nigrostriatal lesion. So this is an example of one. So on the left, it is normal for the lentiform nucleus, the basal ganglia, to have this comma-shaped appearance, right? So that is normal. But in a case of when you have nigrostriatal fiber degeneration, it appears as more of two dot shape, right? So basically what that allows us to do is that allows us to differentiate between a Parkinsonism or Parkinson's disease versus other disorders such as an essential tremor, a dystonic tremor or dopa responsive dystonia, all of which has a normal scan, whereas Parkinson's disease or the Parkinsonian plus syndromes have this abnormal type scan. So it's quite invaluable with respect to that if there's any doubt. This is just a summary of the guidelines with respect to the pharmacological treatment, which is a bit of the scope of this presentation. But basically, within the nice latest guidelines, we have the dopamine precursors, medications such as carbidopa, combined with levodopa. So we have, usually when we have a patient, the preparations of levodopa combined with a peripheral dopa decarboxylase inhibitor, such as carbidopa or bensericide, right? And this is to prevent the peripheral degradation of the L-dopa. So it basically concentrates it beyond the blood-brain barrier. Again, you have your second line medications, your dopamine agonists, your monoamine oxidase B inhibitors, right? You have your catechol-O-methyl-transferase inhibitors, and you have your more experimental ones, such as your antivirals, such as amantadine. Now, in terms of your surgical considerations, so, I mean, this would be a whole topic within itself, right? But this is just basically a bit of key points here. Patients with advanced Parkinson's disease with motor fluctuations, dyskinesias, or troublesome tremor, who are difficult to manage with maximum pharmacotherapy, they may be considered for surgical intervention. So classically, you had lesioning procedures in the form of a thalamotomy or a pallidotomy, but these have now been largely replaced by deep brain stimulation or DBS. And what deep brain stimulation does is that it puts a permanently implanted electrode in the brain in conjunction with a neuropacemaker, a chest wall, and it delivers high frequency impulses. So in terms of our patient selection, we're looking at patients who would most likely benefit from surgery and have adverse effects. We're looking at patients with disabling symptoms. And if the response to L-dopa is now reduced, as it mostly is, we're looking at cognitive functions, and mood should also be assessed by a neuropsychologist. MRI brain should also be carried out to exclude contraindications like excessive atrophy or white matter disease or any focal lesions or tumors, as well as patients on anticoagulation should be held for at least 2 weeks before and after surgery, as well as a speech and swallowing assessment. So in summary, what we're looking at here is we're looking at the targets for in Parkinson's disease for DBS, right? And there are 3 important targets to know: the ventrolateral thalamus, the globus pallidus internus, and the subthalamic nucleus. And dramatic and beneficial effects of both the subthalamic nucleus and the GPI have been reported, and both techniques have been reported to reduce both motor fluctuations and dyskinesias, as well as rigidity and bradykinesia. However, it has been found that subthalamic nucleus stimulation is the preferred target for patients with Parkinson's disease, as it seems to improve all the usual cardinal features of disease. So there was a DBS study group reported that waking time without dyskinesia during the waking hours, it increased from 25 to 30% at baseline to about 65 to 75% at 6 months post-op with deep brain stimulation. And it also markedly decreased the off time. But to date, no large randomized controlled trial shows superiority of deep brain stimulation of the subthalamic nucleus over the GPI. And the following targets appear to improve the following features of Parkinson's disease. So in terms of the tremor, or the VIM, we stimulate the thalamus for the VIM. When we're looking at to improve rigidity, bradykinesia, dyskinesia, or dystonia, we look at the globus pallidus internus. And we look at that again with tremor superimposed. We look at the subthalamic nucleus. So now moving on briefly into the Parkinson plus syndromes, right? And we're looking at multi-system atrophy first. So when we use the term Parkinson plus syndrome, we're talking about a constellation of defined syndromes which have Parkinsonian features, but they don't quite meet the hard characteristics and the UK brain bank criteria for Parkinson's disease, because they're usually characterized by other signs as well. So multi-system atrophy, and it was previously called Scheidegger syndrome, right? It's a alpha-synucleinopathy. And what it is that it causes varying combinations of Parkinsonism. So there's a Parkinsonian variant called MSAP, and it's poorly responsive to L-DOPA in response to classical Parkinson's disease. And there's a cerebellar variant, or MSAC. And there's also one predominantly associated with autonomic failure in the form of orthostatic hypotension, erectile dysfunction, and incontinence and pyramidal signs. The pathology involves unique combinations and locations of neuronal loss in the striatum, substantia nigra, the brainstem, cerebellum, as well as importantly, intermediolateral cell columns and Onof's nucleus in the conus medullaris of the spinal cord, which is important in the physiology for micturition. Mean onset is just a similar age for Parkinson, about 57 to 60 years. So if isolated autonomic failure persists for more than 5 years, the term pure autonomic failure is used. Other clinical features of MSA include rapid REM sleep behavior, sleep apnea, snoring, myoclonic jerks of the fingers, as well as impaired sweating and heat intolerance. So autonomic features. Frank dementia is quite rare and is usually an exclusion criteria for the diagnosis. And the treatment is usually supportive with minor effect from levodopa. In terms of our radiological investigations, so there's usually 2 signs that we look at. On an MRI brain, on this T2 weighted image here, they usually refer to this as the hot cross bun sign, and it's referred to the hypo-intense pattern that we see at the pons, right? That forms somewhat of a cross here, right? So that's called the hot cross bun sign, and it is quite sensitive for multi-system atrophy. Not completely specific, but it is quite sensitive. Sometimes as well, on the T2 image, you could see putamen hyperintensity, right? So you have a hyperintense lesions correlating to where the putamen is. In terms, we're going on to progressive supranuclear palsy, or PSP. It's a tauopathy. It's sporadic and familial, and it classically causes axial akinesia, rigidity, early falls. But why the most striking characteristic in its name is the eye signs. It's a supranuclear gaze palsy, or paresis. And the earliest feature is actually slowing down of the vertical voluntary saccades, followed by supranuclear limitation of voluntary keys. So there's usually a latency in order to initiate saccades, right? Which we call oculomotor apraxia. So ocular features include frontalis overactivity, levator, palpebrae superioris inhibition, and sometimes blepharospasm. You have a complete range of automatic eye reflex movements is usually demonstrated by the oculocephalic maneuver, such as autonomic voluntary dissociation, indicating that the oculomotor pathway from the nucleus distally is intact. So the pathology involves, again, like MSA, neuronal loss and gliosis, as well as neurofibrillary tangles in various parts of the cerebellum, as well as the basal ganglia. And despite having severe postural instability, patients usually fail to widen their base, which is the term motor recklessness, and they often present with a lot of falls, in contrast to Parkinson's disease, where falls are really more of a late feature. So also, unlike MSA and Parkinson's disease, cardiovascular autonomic failure is not really a core feature. However, you may see urinary disturbance. Again, in terms of key radiological features, they describe what we call the hummingbird sign of PSP on these T1 weighted sagittal images. And it's usually due where the arrows point due to the atrophy of the midbrain. So it gives the impression of a hummingbird, basically. Also, another very specific ratio is the reduced midbrain to pontine width ratio. So usually, if we do a midbrain to pontine width ratio, it's usually less than 0.52. And this is quite indicative of PSP. Or if we do an absolute midbrain width, if it's less than 9.35 millimeters, that is also quite sensitive and specific for PSP. So just a bit of key information there. In terms of cortico-basal degeneration, again, it's a topathy, and there are different molecular variants. What the patients presented here is asymmetric and progressive evolution of symptoms. It starts in one hand or leg with difficulty in using the limb, and it progressively becomes useless due to a combination of akinesia, rigidity, dystonia, as well as myoclonus and tremor, in addition to cortical sensory loss and apraxia. So what they call this cortical sensory loss, basically, it's almost as if the limb is behaving by itself, and they refer to this as the alien limb phenomenon. And the progression is to the opposite side of the limb, on the or on the same side, but ultimately all four limbs are affected, and a supranuclear gaze palsy may or may not develop later, in contrast to PSP, which is an early feature. So again, the pathology involves swollen or ballooned cortical neurons in the frontal and parietal areas with tangles and plaques. So we look at vascular Parkinsonism. These patients usually have a lot of cardiovascular risk factors, and they have a lot of multiple infarcts, and commonly have a lot of multiple basal ganglia lacunes or deep white matter vascular disease. So it could sometimes mimic Parkinson's disease or even true Parkinsonism. It typically presents with spontaneous movements or facial expressions is good, and with slowing of finger movements, or they could present with pyramidal signs. But there's no classic fatigue or decrement of motor amplitudes, in contrast to Parkinson's disease. The gait could be wide-based or unsteady or small step. So they refer to this as a march, a petit pas, rather than a shuffling or fascinating gait of Parkinson's disease. So this is just an example of vascular Parkinsonism on MRI brain. You see what we term leukocariosis, or a lot of deep white matter changes indicative of small vessel disease or lacunes. So importantly, we leave Parkinsonism and Parkinson's disease and we move on to tremor, right? Which is also quite relevant here. We define a tremor. It's a rhythmic sinusoidal alternating movement. And it could be described in several ways, meaning it's rest, if it's postural, action, if it's terminal, or if it's an intention tremor. One of the most common tremors that we meet is the benign essential tremor. It's usually autosomal dominant, and most patients usually have mild or little disability. No gene has been identified in order to cause the majority of essential tremor, but it usually involves both arms first symmetrically and to a greater degree other body parts, such as the neck and the legs and the voice. The tremor is usually vertical, that of a flexion extension type of tremor, as opposed to a supination, pronation type tremor, which we see in Parkinson's disease, or that pill rolling tremor. So usually more flexion extension, and it usually worsens over years. But it rarely causes marked functional impairments. And one key feature is that it usually improves after alcohol, but it could also be aided with beta blockers, primidone, gabapentin, or topiramate. So there are different types of tremors which could be mistaken as a benign essential tremor, such as a dystonic tremor, as well as a enhanced physiologic tremor, as well as other conditions that cause postural tremor as well. So one of the basic bedside types of tools that we have is the basic Archimedean spiral. We have a control on the right, and we get the patient to basically draw a spiral. And this is the pattern that we usually see with a benign essential tremor, and it's fairly diagnostic, and it's something that can be done easily at the bedside. We look at dystonic tremors. It's usually poorly defined and mistaken for a benign essential tremor or benign tremulous Parkinson's disease. Dystonic tremor implies a tremor in a body part, also displaying overt dystonia. It's usually asymmetrical, relatively slow, pronating, supinating type, and it comes in flurries. It could be associated with abnormal or reduced arm swing or a jaw tremor in about a third of the patients. So when a patient has a tremor with these characteristics, but no evidence of dystonia, we call it an atypical tremor. So note well that both essential tremor and dystonic tremor could be both treated by botulin toxin A type injections. We have the neuropathic type tremor, which we see in different neuropathies, such as that associated with your your monoclonal gammopathies. And they're usually somewhat of a resting type tremor. However, the severity usually does not, of the tremor does not usually indicate the severity of the neuropathy or the degree of deafferentation. Cerebellar or intention type tremors is usually caused by brainstem or cerebellar outflow pathway lesions. So the most common cause of this is multiple sclerosis. The tremor is not just action or terminal, but worsens steadily throughout the entire trajectory of the movement. And it's usually a difficult type of tremor to treat, with a lot of drug treatments being typically unhelpful. We have what we refer to as the Holmes tremor, and it's previously called a midbrain tremor or the rubral, meaning the red nucleus tremor in the mesencephalic area. It's called a three-part type tremor. So it incorporates tremor at rest, during postural changes, as well as during action or intention tremor. So it's one of the few types of tremors that's a three-part or tripartite tremor. And it's caused by a combination of damage to the cerebello, rubrothalamic, and nigrostriatal pathways. So usually when you have infarct to the midbrain, as the most common cause of a Holmes tremor, usually when it affects the red nucleus. So interestingly here, we have the palatal tremor. And it's a combination of rhythmic contraction of the soft palate, and it could take the form of two entities. So we have essential palatal myoclonus, which is usually more benign, and it usually is not disruptive to the patient. And we have symptomatic palatal myoclonus, which is usually more disruptive to the patient. And it involves the disruption in the connections in a type of triangle, an eponymous triangle called the Guillain-Molleret triangle, between the dentate nucleus, the red nucleus, and the inferior olivary nuclei. And essential palatal myoclonus usually consists of rhythmic contractions of the tensor veli palatini, innervated by cranial nerve 5, and symptomatic palatal myoclonus usually involves tremor to the levator palatini, innervated by cranial nerve 7. So what the patients complain of, in EPM, they usually complain of clicking, and it usually, as opposed to symptomatic palatal myoclonus, this persists in sleep and is often associated with, if we do an MRI scan, inferior olivary hypertrophy, as well as rhythmic and oscillatory limb movements. So both of these entities, clonazepam, could help both symptoms. And this is the triangle that I was speaking about, this eponymous anatomical pathway, the Ian-Mullary triangle, between the red nucleus, the inferior olivary nucleus, and the contralateral dentate nucleus. So usually there's some sort of disruption in this triangle here, which causes essential or symptomatic palatal myoclonus. And again, this is just an MRI demonstrating hypertrophy or involvement of the inferior olive. It's usually quite characteristic of palatal myoclonus. And in terms of one of our last types of tremors, we're looking at orthostatic tremor. And it's usually rare, but the patients usually feel unsteady and tremulous while standing, but not on walking. And they usually prefer to sit down or keep moving. It's a high frequency tremor, so 13 to 16 hertz tremor of usually of the leg muscles, of the lower limb muscle, which can also be palpated and auscultated, but you can't really see it. And clonazepam again usually aids in the symptoms. And of course, there's a large number of medication and pharmacological causes of tremor as well. So we call this drug-induced tremor. Most notably caffeine, nicotine, lithium, SSRI, TCAs, thyroxine. This diagram basically illustrates what I was showing a bit earlier with respect to the Archimedean spirals. And we could actually see the different patterns here that could be quite diagnostic of the different movement disorders. So we have the control or the normal. Parkinson's disease, we see it's on the smaller side, micrographia. Benign essential tremor, as seen before, and a dystonic tremor. So with a dystonic tremor, we'll move on to dystonia. What is dystonia? It's a heterogeneous movement disorder characterized by involuntary muscle spasms leading to abnormal body postures. So typically, the spasms in dystonia are mobile and they lead to slow writhing parts of the affected body. So they involve contraction of the agonist and antagonistic muscles, and that's seen as being an underlying reason for the abnormal posturing. And it's very obvious on clinical exam as well as an EMG assessment. So most recent guidelines suggest that a tremor is an integral part of dystonia. That's the most recent guidelines, and it includes it within its definition. It could be task specific or position specific. So one of the important position specific dystonias that we would hear about is writer's cramp, which is an actual type of dystonia. So another characteristic feature, particularly of focal dystonia, such as writer's cramp, is the presence of a sensory trip or gest antagonist. So if we apply a sensory stimulus or someone else applies a sensory stimulus to a particular area, it could actually cause the dystonia to resolve quite quickly. The mechanism of this is largely unknown, but it has been known in the literature to be a very characteristic feature of dystonia. In terms of the classification of dystonia, we could classify it by etiology, distribution, and age of onset. And that age is quite important, less than 28 years and greater than 28 years. Focal, multifocal, and more widespread called hemidystonia. Dystonia is the only clinical sign apart from tremor in primary dystonia, right? We see the etiology here, we have primary dystonia. So only dystonia is present, and there is no evidence of neurodegeneration. So features in the history and the exam that might be suggestive of a secondary cause of dystonia. So usually in these patients, they may be younger, And we want to look at a birth history, a developmental history. We want to examine for the presence of any bulbar signs or if any unusual natures of the dystonia, right? Any fixed postures, the presence or absence of seizures, as well as the presence of any organomegaly, right? As well as the presence of exposure to any drugs such as dopamine receptor blockers. So again, this is just a table basically summarizing the different types of investigations that we could use in a patient that we suspect with secondary dystonia. And there are a large number of different causes, right? And this could be read at your convenience, but basically MRI brain to rule out leukodystrophy or brain iron accumulation disorders, copper studies and slit lamp tests to rule out Wilson's disease. We look at blood smears to rule out neuroacanthocytosis or blood film, as well as different types of biopsies. We're looking at the different glycogen storage disorders. So one of the last things here is primary dystonias, dystonia plus syndromes, dopa-responsive dystonia, myoclonus dystonia, symptomatic dystonia, and heredodegenerative dystonia. Primary dystonia, as stated before, the only key clinical feature is that of dystonia plus or minus tremor. Age is important, and most of these patients only carry a single CAG deletion in the DYT1 gene. Usually develops in later in life, and it could include cervical or cranial dystonia, as well as laryngeal involvement. The dystonia plus syndromes, there's no involvement, there's no association or evidence of neurodegeneration, but it's usually restricted to that of dystonia plus Parkinsonism or myoclonus. Dopa-responsive dystonia, it usually mostly presents in childhood at the lower limb, and there's a diurnal fluctuation in symptoms with a gradual worsening throughout the day, and it's usually treated with small doses of levodopa. Myoclonus dystonia, autosomal dominant, there is an abnormality in the epsilon cycloglucan gene, and it presents with early onset with a combination of myoclonic jerks, and it responds quite dramatically to alcohol. The myoclonus worsens with movement, and there's often more prominent. This is actually more, the myoclonus is more prominent than dystonia, hence why they call it myoclonus dystonia. Usually have a lot of different psychiatric features as well. Symptomatic dystonia could be secondary to a number of different causes which affect the basal ganglia, such as the most common is that of following a stroke. It's usually a static deficit, so it usually doesn't worsen. However, the onset could be delayed for several weeks or even months or years after cerebrovascular insult, right? So the heredodegenerative dystonias, right? This is just a simple slide that basically kind of clues you into what to think, right? If you have a patient that presents with a peripheral neuropathy and a dystonia, we think, could this be a metachromatic leukodystrophy, all right, or white matter disorder of the brain, or neuroacanthocytosis? If we have a patient that presents with dystonia and a flapping tremor of the face as well, we have to think, is this Wilson's disease? If you have a patient that presents with prominent ataxia and dystonia, is this spinocerebellar degeneration, particularly type 2 or 3? And if they present with bulbar involvement, mainly of the tongue, right, could this be secondary to a number of different disorders, right, such as brain iron accumulation disorders, Lesch-Nyhan, Nyman-Pick type C? So it's just a basic algorithm in order to get you into thinking of the secondary types of dystonias, which again is more or less beyond the scope, right? But one of the main disorders that we have to talk about, right, briefly is that of Wilson's disease. And it's the predominant and most common hereditary-degenerative this type of dystonia. Why it's important is because it's very treatable. And if left untreated, it is very fatal. So it's an autosomal recessive disorder of copper metabolism, and it presents in the first 2 decades with the ATP7B gene on chromosome 13. Patients can present with usually acute liver failure due to copper deposition, hepatitis or cirrhosis, as well as hemolytic anemias. They also present with a number of behavioral neuropsychiatric symptoms. Early gait abnormalities are frequent, and mixed movement disorders are common, such as rhizostomy sardonicus, or the tightening of the masseter, as well as a pseudobulbar palsy. And left untreated, patients could develop seizures and pyramidal signs. So one of the main takeaways basically is that this is why a slit lamp examination is so important in these patients, is to look for the presence of the Kaiser-Fleischer rings, which are quite pathognomonic of Wilson's disease. And this is just a picture illustrating that. As we see that it's more or less Wilson's disease. Emergence of Parkinsonism, dystonia, and tremor in adolescents with a slurred speech greatly raises the possibility of Wilson's disease. We have the combination of low serum ceruloplasmin and hepatic copper concentration, more than 250, is quite diagnostic, as well as increased urinary copper, as well as more non-specific brain MRI findings in the brainstem, basal ganglia, as well as the cerebellum. So this is an example of that, right? Of the brain findings, of the MRI brain findings within Wilson's disease. Penicillamine is the main drug of choice for chelation, and it should be monitored. Trienterine is another chelator of choice. Oral elemental zinc induces intestinal proteins to bind copper in the enterocytes of asymptomatic patients, and anticholinergics can help with the dystonia or the akinetic rigid syndrome. In cases of rare fulminant hepatic disease, liver transplantation is warranted. In terms of our general management of dystonia, the first-line treatment are anticholinergics, such as trihexyphenidyl. Clonazepam is useful in the treatment of tremor and jerks, as well as the pain associated with dystonia. There's also the other medications, such as tetrabenazine, baclofen, and dopamine receptor drugs, such as prolactin. Botulinum toxin A has been recently introduced, and this could be done every 3 to 4 months on an outpatient basis, with a reported 70 to 80% improvement in the symptoms, particularly in patients with head and neck dystonia, such as cervical dystonia or blepharospasm. In terms of our important surgical targets, globus pallidus interna, the subthalamic nucleus, as an alternative target to the GPI, and the ventro-intermediate-lateral nucleus of the thalamus, more for tremulous dystonia. Penultimately, we're looking at myoclonus. It's defined as a sudden, brief, shock-like voluntary movement caused by muscular contraction or inhibition. It could be focal, multifocal, generalized, spontaneous, or reflexive. And we could classify it as cortical, subcortical, spinal, or peripheral based on the physiological mechanism underlying its degeneration. So this is just a table from an article from the British Medical Journal, Neurology Journal. It basically breaks up the causes according to the site of generation. So you have your cortical myoclonus, and it includes a number of different diseases, such as Huntington's disease, Parkinson's disease, Rasmussen's encephalitis, amyloid angiopathy. Subcortical myoclonus, so it could be variant Creutzfeldt-Jakob disease, or the different prion diseases, palatal myoclonus, as we talked about before, different metabolic abnormalities that could cause it as well, such as renal failure, uremia, and mixed cortical and subcortical spinal disorders such as Alzheimer's disease, right? We have physiologic myoclonus, so in the form of hypnic jerks in the initial phases of sleep, which are completely physiological, hiccups in the form of myoclonus of the diaphragm, and a startle response, which is usually exacerbated by anxiety. We have epileptic myoclonus, which are usually jerks associated with part of an epileptic syndrome. And they could occur in the syndromes of idiopathic generalized epilepsy, which includes progressive myoclonic epilepsies as well, mainly that syndrome. we look at a very important type of myoclonus, especially in patients in our neuro patients with the ICU who have severe traumatic brain injury, which is the post-anoxic action myoclonus or Lance-Adams Lance-Adams syndrome. Usually due to cerebral severe hypoxic brain injury or cerebral anoxia, and it usually occurs after a latent interval of 24 to 48 hours. It could be positive and triggered by movement, or it could be negative when the limbs are outstretched against gravity. It is most commonly a cortical reflex type myoclonus, but reticular reflex myoclonus and exaggerated startle may also occur. Why this is important is because it's actually a prognostic factor in patients with severe traumatic brain injury. The presence of this type of myoclonus it indicates a poor prognosis. Depending on our different factors as well, such as the motor state, pupillary function, as well as an EEG findings and whatnot, especially after post-cardiac arrest as well. You also have opsoclonus myoclonus, such as in several types of cancers in childhood, such as neuroblastomas and medulloblastomas. It could also be post-infectious and metabolic related, and it's usually characterized by rapid involuntary eye movements as well as involuntary muscle contractions. It's mediated by autoantibodies against onconeural antigens. You have myoclonus in neurodegenerative disease, so seen in patients with Lewy body dementia, Parkinson's disease, as well as multi-system atrophy. And these could be demonstrated on EMG as well as nerve conduction studies as well. Also importantly, we have new variant, Creutzfeldt-Jakob disease, or mad cow disease, or the different prion diseases, which myoclonus is quite an early sign. Spinal myoclonus, right, has been reported in association with spinal cord trauma or vascular disease, discerniations, or infection. It usually occurs when the patient is relaxed and predominantly when lying in the bed or falling asleep, and it could cause insomnia in that it's usually disabling. In terms of our treatment, it depends on the underlying disorder. Most of these respond quite poorly to pharmacological treatment, and they require polytherapy. Sodium valproate combined with piracetam and levetiracetam or Keppra is quite good. Benzodiazepines and barbiturates are good in that they promote GABAergic transmission, as well as clonazepam, another benzodiazepine. You have a role for bilateral pallidal deep brain stimulation with severe myoclonus dystonia, and botulinum toxin A for hemifacial spasm and palatal myoclonus. And then lastly, we talk about tics. A tic is a relatively brief, rapid, intermittent stereotype involuntary movement, which could be motor or it could be vocal. Common tics are eye blinking, elevation of the shoulders, facial grimacing, or vocal being a sniff or grunt, and they could be suppressed. But this usually comes at the expense of the anxiety rising in the patient, so it leads to rebound exacerbation of further tics. So most are abrupt in onset and duration, which are called tonic tics, but could be slow and sustained, either dystonic or tonic. One of the important disorders is Tourette syndrome or Gilles de la Tourette syndrome, right? And there's a specific criteria for this in that it must occur before the age of 18, multiple motor tics. It could involve vocal tics. The tics usually evolve in a progressive way. They wax and wane. They usually have a duration of longer than 1 year, and there's usually no precipitating or antecedent illness. Tics could be simple, like eye rolling, or complex in the form of squatting. You do often have an aura or premonitory sensations that could precede in about 80% of patients. New tics could appear in response to new somatosensations, such as a cough that could persist as a tic after an upper respiratory tract infection. So other important and more well-known features to the layman is that of echolalia, which is mimicking what a person says, as well as coprolalia, in that the uses of obscene language. Um, this is actually a quite rare symptom, so it's seen within the minority of these patients, right? Especially the usage of the foul, uncontrollable foul language or obscene language. So it's not needed in order to make the diagnosis of Tourette syndrome. Most of these patients, at least 90%, have some kind of psychiatric comorbidity, mostly being ADHD, followed by obsessive compulsive behavior or obsessive compulsive disorder. There's different theories that have been proposed in relation to the etiology of tics, including anti-basal ganglia antibodies, different metabolic conditions, prenatal and perinatal infections, as well as an implicated role in Streptococcus A. Other forms of tic disorders include a transient tic disorder, chronic vocal tic disorders, and those that are not otherwise specified. So usually those appear after 18 years of age, as opposed to Tourette syndrome. Principles of management, it's an MDT approach in the form of reassurance, psychoeducation, psychotherapy, cognitive behavioral therapy, as well as antipsychotic medications, antidepressants. There's a role for botulinum toxin A injection, especially in the vocal cord, for disabling vocal tics and deep brain stimulation of the internal capsule, the GPI, or the thalamus. And then lastly, right, chorea, it's a state of excessive spontaneous movements, irregularly timed. The severity can range from restlessness to mild intermittent exaggeration. There's a whole number of different gamma causes of chorea, which could be inherited or acquired. But the one that we would just talk about briefly is that of Huntington's, because that's the most common and that's the most implicated one. It's a slowly progressive autosomal dominant disorder before the age of 40 years. Usually starts occurring, that usually proceeds 15 to 20 years from onset. And the key takeaway point here is that it's caused by a CAG repeat expansion. It's a defect in the CAG triplet. These triplets could vary with each generation, and this actually underlies the principles of anticipation, meaning that with each subsequent generation, right, because of the way of the inheritance of the disease, the onset of disease actually becomes earlier, and patients actually, the phenotype is more severe. Again, it's a very clinical phenotype, and as the disease progresses, the signs and symptoms change. So disease duration could markedly modify the clinical presentation. The different motor, cognitive, and psychiatric features, right? Abnormal eye movement, hyperreflexia, impaired fidgety movements of the hands or nose, saccadic abnormalities, extrapyramidal signs, impaired executive function, poor planning, poor concentration, and is often accompanied by depression and anxiety, as well as psychosis in the late stages. Again, there's the different causes or the secondary causes, the main different secondary causes of chorea. Could be drug-induced, metabolic conditions, role for streptococcus in the form of pandas, right? Or pediatric in the pediatric population, and benign hereditary chorea, right? And that is it, right? That's the end of the presentation.